Preeclampsia is one of the hypertensive disorders that can occur during pregnancy as well as up to 6 weeks postpartum. In this video, we will focus on preeclampsia. Okay, you guys, this is serious. Failure to recognize and treat the signs and symptoms of preeclampsia can quickly lead to life-threatening conditions for both mother and fetus, so listen carefully. The diagnosis for preeclampsia is made when a woman's systolic blood pressure is greater than 140 millimeters of mercury or diastolic greater than 90 on at least 2 different occasions after the 20th week of gestation. So that's key, after the 20th week of gestation. And also tests positive for proteinuria, an abnormal amount of protein leaking into the urine. While the cause of preeclampsia is unknown, it is thought to have something to do with an abnormal development of the placenta, which affects perfusion and oxygenation to the fetus. The widespread vasoconstriction and endothelial dysfunction have a negative effect on the body's ability to adjust to the increased blood volume in pregnancy. Oftentimes, patients can be totally asymptomatic when they present to the clinic or hospital. Fortunately, preeclampsia is caught during routine screening, which is one of the reasons why prenatal care is so important. In addition to the high blood pressures and proteinuria, patients may complain of a headache that is unrelieved with Tylenol, visual disturbances such as blurred vision, seeing spots, and a sensitivity to light, right upper quadrant pain where the liver is located, and swelling in the face, hands, and feet. If unrecognized or untreated, preeclampsia can progress quite rapidly. A severe range blood pressure is a systolic reading of 160 or more, and a diastolic blood pressure greater than 110. The patient can develop pulmonary edema, a fluid buildup in the lungs, and thrombocytopenia, a decrease in blood platelets that can cause problems with blood clotting. Progressive organ system involvement is another key feature of pre-E with severe features. Impaired kidney function can cause oliguria or decreased urine output. If liver injury is present, we will see increased levels of the liver enzymes ALT and AST, as well as persistent right upper quadrant or epigastric pain. There are several complications that can occur for both the woman and the fetus as preeclampsia progresses. A main concern with pre-E is placental abruption, when the placenta separates from the lining of the uterus prior to delivery. You'll want to monitor for vaginal bleeding, abdominal tenderness, or rigidity. A progression from preeclampsia to eclampsia is the presence of seizures, and this is a serious situation that would require an emergent delivery once mom is stabilized. Other risk factors for the woman include HELLP syndrome, stroke, DIC, multi-organ failure, and death. In the fetus, we'll see complications such as IUGR or growth restriction. The fetus is also at risk for the complications that can occur with preterm delivery, as well as IUFD or fetal death. A development of any of the severe features or complications we've discussed would result in an emergent delivery, regardless of the gestational age of the fetus. Some of the top risk factors in developing preeclampsia are a woman's first pregnancy, a personal and/or family history of preeclampsia, advanced maternal age, diabetes, obesity, and multiple gestations. So let's talk about the different plans of care. Expected management of the stable preeclamptic patient includes continued monitoring and frequent follow-ups, bed rest at home or in the hospital, blood pressure control, and plan for delivery at 37 weeks. As the nurse, you'll be at the bedside doing frequent blood pressure monitoring. This includes selecting the correct blood pressure cuff size. That's oftentimes a mistake that people make. Seizure precautions, so you're going to want to have those side rails up and padded and oxygen nearby. Continuous fetal monitoring and hourly mag checks. You'll also want to limit visitors in order to keep the hospital room dark and quiet. This will help the patient rest, keep their blood pressure down, and help with headaches and sensitivity to light. Oftentimes, I have patients hospitalized with preeclampsia, and they'll have 5, 10 visitors, family members coming in and out to visit the patient, having loud conversations, and that just really doesn't help the patient rest and relax and stabilize her pressures. Magnesium sulfate is one of the medications that's given to the patient for the prevention of seizures. Hourly mag checks should be done to assess for magnesium overdose. You're going to check blood pressure, lung sounds, deep tendon reflexes, urine output, and assess for signs and symptoms of worsening pre-E. The antidote for mag sulfate is calcium gluconate. Antihypertensives such as labetalol and hydralazine are given IV push to help control severe range BPs, and nifedipine can also be given orally. Betamethasone is a corticosteroid that is given prior to 34 weeks to help accelerate fetal lung maturity in order to prepare for a possible preterm delivery. It is so important to educate the patient and her family and stress the seriousness of the disease process and the risks to both mother and fetus, while also providing emotional support. The patient should understand the signs and symptoms to look out for, and she should know to report to the hospital immediately for any signs of pre-E, as well as vaginal bleeding, leakage of fluid, or decreased fetal movement. With early recognition and treatment, preeclampsia can be treated for the safety and well-being of both the mother and the fetus.